Nicole McKinnon. I'm one of the staff physicians in the pediatric ICU at the Hospital for Sick Children, and I'm going to talk about strategies for neuroprotection. So what is neuroprotection? Well, if you look it up, what you see is it's defined as strategies to protect neurons against damage or impairment of neurologic function with the goal to prevent poor neurologic outcome. And I find this a rather circular definition, and I believe everyone's goal with our patients is to prevent a poor neurologic outcome. So what we're really going to focus on today is why are patients with congenital heart disease at risk, understanding what is vulnerable about their brains, identifying the risk for neurologic injury in these patients, of which I think you've already heard some by the previous speakers, describing the physiology behind the prevention of secondary brain injury. We will describe neuroprotective strategies, but really focusing on taking it to the bedside, the neuroexam and neurovital targets. And as my dear friend the brain likes to say, the brain is the most important organ you can have according to the brain. I have no conflicts of interest to disclose. And I'm going to start off with an unfortunate fact, which I think many people have probably addressed today, which is children born with congenital heart disease have worse long-term neurologic outcomes compared to their peers. And this actually speaks to how impressive the care for patients with congenital heart disease has been in the last 30 to 40 years. Because of advancements in surgical technique, anesthesia, and critical care, these patients now live long enough to have long-term follow-up. And this has led to groups like the Cardiac Neurodevelopment Outcomes Collaborative, which has really been studying these patients. And what they found is that irregardless of whether it is a mild or severe complicated palliated congenital cardiac defect, these children are at risk. And even those with mild disabilities have disabilities that are quite, that affect them in school. So specifically areas of cognition, memory, attention, and language. And so the goal is to understand how can we improve on these outcomes as we continue to care for these children. So the first thing to address is that these children are born with vulnerable brains. And this study that you're looking at here is by Stephen Miller, who's at the Hospital of Sick Children, and there is an ongoing large collaborative between him and Dr. Seed here. And this is imaging the brains of patients born with congenital heart disease. And even prior to having any form of surgical intervention or going on bypass, these children have widespread brain abnormalities. And so they're born with an abnormal brain. The imaging studies have shown that they have abnormalities in their brain metabolism, which is what's being shown on the top of your screen there. That's an MRI looking at the ratio of lactate to choline in a patient with transposition of the great arteries. And the other abnormality that is found significantly more in patients with congenital heart disease is white matter injuries. And up to 55% of these children born with congenital heart disease have white matter injuries. The other group that is known to have white matter injuries is really premature infants. And so in many ways, a baby born at term with congenital heart disease is actually born with a brain that is much more similar to a premature infant, and in that way is actually born with an underlying brain injury. And this diagram here was published in Trends in Neuroscience in 2015. And what I think it does is really shows that beyond the fact that these children are born with vulnerable brains, they have periods of time, both early on, preoperatively, and throughout childhood and adolescence, where they are exposed to things that are going to significantly increase their neurologic risk, be it hypotension, hypoxemia, the risk of reperfusion, multiple rounds of anesthesia, and then concurrent things like sedation, embolic events, sedatives. So our goal really should be, when caring for these patients at bedside, is to anticipate, prevent, and halt secondary brain injury. So before we talk about how we can do this, let's talk a little bit about the pathophysiology of brain injury, because it's important to understand what is different about it relative to, say, other forms of organ injury. So first off, you don't have the ability to regenerate neurons. There is some data that you can have a small number of neurons regenerate in the hippocampus, but really on a global perspective, the neurons you're born with are the neurons you have. And when you have periods of ischemia and neuronal loss, you don't get those neurons back. But besides for that, neuronal injury is feed forward, which really means that even a small area of ischemia, and this is going to be the example of a stroke, can lead to actually a large loss of brain tissue. So ischemia here, so from a stroke, an arterial thrombotic stroke, causes a loss of tissue oxygenation. That causes a loss of ATP, and as such, at the neuronal level, you have a loss of your sodium potassium ATPase that is dependent on the ATP. This leads to an intercellular increase in sodium in the neuron, and that causes membrane depolarization. And normally, membrane depolarization is caused by an increase in sodium, but it's in a controlled manner. Here, the ischemia has caused a loss of those safety mechanisms. And so you get membrane depolarization, which opens voltage-gated calcium channels, and those are there to release excitatory neurotransmitters, in this case, glutamate. And glutamate goes across the gap from the presynaptic cell in the neuron to the postsynaptic, where it causes depolarization of the postsynaptic cell. And that propagates what's known as neuroexcitotoxicity. And so you can understand here that a small area of ischemia actually is setting neurons up to poison the neurons surrounding them. And it feeds forward. And this is how you end up with areas of inflammation, apoptosis, well beyond the infarction area. And this is known as the penumbra in a stroke. And so this is what's unique about brain injury. So let's talk about anticipating brain injury in the congenital heart patients at the bedside. Well, I know you've heard a lot today about different risk factors in these patients, and so I won't spend a ton of time talking about it, but it's important to recognize that the cardiac physiology increases the risk. And so here I'm just showing a couple of examples. The single ventricle patient, obviously we understand, has a stage surgery where they are at risk throughout those stages. Tetralogy Fallot has a high risk of stroke given their large VSD. But besides for that, in the middle, all of the other things that come with sort of having congenital heart disease, including abnormal coronaries, arrhythmias, all of these things can set the patient up for situations where they are at risk for neurologic insult. So one of the unfortunate things that can occur in patients with congenital heart disease is that actually a study in 1999 showed that 6% of patients who have congenital heart surgery of all types have a cardiac arrest. Now, this is a slightly older study, but 6% is a significant number, and 41% of those patients survive to hospital discharge. A more recent study has really highlighted the risk, and this is shown on the figure here, of patients with stage 1 shunted single ventricles, of which 20% of them in hospital receive CPR. 33% of those survive to hospital discharge. But a larger study, the THAPCA study, recently showed that in pediatric in-hospital cardiac arrest, those that survived, only 39% of them had a favorable outcome at 1 year. And so we already know that these patients have vulnerable brains. And we also know that they have a high risk of cardiac arrest. And after a cardiac arrest, you have a low chance of a favorable outcome. Now, the last presentation talked heavily about stroke, so I won't go into it too much except to say that the studies on pediatric stroke, and this was the McKay et al. Study in 2011, really looking for the prevalence and risk factors of pediatric stroke, highlights that up to 33% or 31 here of patients who had thromboembolic events there had an underlying cardiac disorder. And I think it's again highlighted in the fact that the highest incidence of pediatric stroke occurs in the under 3, which is where you have a high percentage of patients with congenital cardiac disease going through stage surgeries. So the presentation of stroke in pediatrics, unfortunately, requires a much higher sense of attention than potentially in adults, where the adult stroke is very classic, especially if it's a large middle cerebral artery. You have the classic facial droop, arm weakness, and slurred speech. But in pediatrics, the first-time presentation of stroke is often a first-time seizure. The focal neurologic deficits can be subtle. So sometimes they can be significant, like a hemiparesis, but they could include a young child using the non-dominant hand or refusing to walk and wanting to be carried. They can include headache, irritability, fussiness, and vomiting. And so we have to have a large amount of vigilance at the bedside and really think about stroke as a potential for our children who are at risk. As we discussed that the congenital cardiac patients are at high risk. So neuroprotection at the bedside begins with a physical exam. And this is a paper really focused on adults, published in 2013, but basically what it summarizes is what I think all of us know, and that's the clinical examination is the cornerstone of assessment of patients. And it's essential for the detection of neurologic disorders complicating critical illness. And they broke down the exam into two sets of patients, the neurologic exam in critically ill patients. The conscious patient, for which they recommended assessing cognition, including orientation, language, attention, memory, cranial nerves, motor and sensory function, reflexes, and coordination. They make recommendations for serial examinations to discern trends and see evidence of deterioration. That if the patient is sedated, that sedation should be reduced at least daily for a daily evaluation. And that once the sedation is being weaned off, that the patients are evaluated for delirium. And as I mentioned, that this study was focused on adult critical care. And it's much easier in adults to get an orientation to who is the prime minister and what year it is. However, it is possible to do a complete neural exam in the PICU or in the cardiac ICU in children and infants. And it comes down to paying close attention, looking for facial symmetry when they smile, when they cry. Is there any sign of eye droop? Do they not stick out their tongue evenly if you make faces with them? And all of these are signs of deficits with cranial nerve 7. Can they fix and follow? This is a sign of higher cognition. Do they attend to interesting toys or their parents' voices? Again, checking on cranial nerves, but attention. Do they move all sides equally? And here I like to do things like get my kids to give me high fives, especially the toddlers, if I can get them to give me a high five. And often they won't want to use the hand with the IV in it, but it's really important to assess it. And so, I'll get them to give me a high five on that side first and then the other one. For my older kids, can I get them to give me a thumbs up? And I never ask a patient to squeeze my hand because you can have a neonate do that. It's a spinal reflex. But giving a thumbs up involves a vast number of processes, from fine motor to gross motor, cognition, cranial nerves with hearing. And so if you can get your patient to give you a big thumbs up on each side and hold those arms up, you're checking the cerebellum, the cortex, the cranial nerves, the brainstem. It is a fantastic test. And I make my kids do it every morning when I see them if they are not heavily sedated, and every evening. Do they move all extremities? Watching them closely, get them to wiggle their toes in bed, pretend they're driving a car. The neurologic exam in a comatose patient, well, here the recommendation was to do a neurologic assessment, which considers the level of arousal, brainstem function, motor responses, and respiratory pattern. And this can be more challenging. And here is where I recommend using a Glasgow Coma Scale, which unfortunately is not meant for patients outside of traumatic brain injuries, but it's very helpful in breaking down sort of what their overall function is and having some understanding of their prognostication. The one thing I always ask, though, is that I get a breakdown, a total, not a total score out of 15, but what is the E today, the V today, the M? And just keeping in mind for the group that if you have a patient with a severe neurologic injury, decortorate posturing is M3, and that's where they pull their arms up on their chest towards their head. And decerebrate is M2, and that's where they're pushing their hands away down from them. Okay, so moving on to prevention. So the neurophysiologic targets that we want to monitor and target at bedside really fall into two categories. The first is focused on cerebral blood flow and regulating that. And the second is focused on decreasing neurometabolic demands, which increase the toxicity and damage in neurons. So regarding cerebral blood flow, preventing hypoxemia as best we can, avoiding hyperoxemia, preventing hypotension, preventing and controlling intercellular hypertension, targeting CO2s, which provide good venous drainage, but don't have a significant impact on intracranial pressure. We'll talk about these on the next slide. And head positioning all really fall under the target of cerebral blood flow. And then decreasing neurometabolic demands. We have good temperature management, prevention of hypoglycemia, and close monitoring and quick termination of seizures. So I'd say this slide here is really the overall targets. And granted, these need to be adapted for the patient, but in general, head of the bed should be midline. This is for good venous drainage from the brain, again, targeting that cerebral blood flow. The bed positioning should, in general, be 30 degrees unless the patient is post-ischemic stroke, and then they're laid flat to encourage good perfusion through their carotids of the ischemic area of the brain. The temperature, to me, is the easiest place that we can make a huge difference. So really the goal is normothermia and afebrile. 36 to 37.5 is a target. Anything higher than that should be treated, whether that's with Tylenol, NSAIDs if the patient can receive them, cooling and neuromuscular blockade if they are intubated. And then there are targeted temperature management, and these subgroups include, for some post-cardiac arrest patients, targeting temperature of 34 degrees for 2 days and then normothermia for another 3. Or for ICP control, where for a patient with refractory intracranial pressure, you can target their temperature management of 32 to 34. Targeting blood glucose of 5 to 10. We know that below that, we have an increased risk of seizures, and glucose is a primary nutrient source for neurons, but also above that, profound hyperglycemia is toxic to neurons. That we should set cerebral perfusion pressure goals. And to remind everyone, the cerebral perfusion pressure is the MAP, the mean arterial pressure, minus the intracranial pressure. And so really often what we are doing is assuming an intracranial pressure, since most of our patients don't have ICP monitors, but generally ICPs are between 8 and 15 in a normal adult or child laying down. So assuming somewhere between 15 or greater than 20 if you know your child has a neurologic insult, and working back as to what the required mean arterial pressure is to target a cerebral perfusion pressure. We'll go through the cerebral perfusion pressures on the next slide. And then the end tidal CO2, or the PA CO2, again, 35 to 40, and this is really to control venous drainage and within the brain and control that cerebral blood flow. That the fluid balance in patients to be neuroprotective should have a serum sodium that is normal or stable for that patient. Taking into consideration some patients with heart failure may be persistently hyponatremic, but its quick changes and shifts in sodium have significant complications for neuroprotection. And that these patients in general should be, if you're concerned about a secondary injury or a recent stroke or cardiac arrest, these patients should be on 0.9% sodium chloride containing fluids. And then, as I hinted at, seizure control is essential. It decreases the neurometabolic demand in the brain. It helps prevent that area in that penumbrum with a stroke from becoming ischemic. So it preserves brain tissue. So early detection, early EEG, early treatment. So this is my favorite slide, and I think it summarizes all that we need to focus on with cerebral blood flow regulation. So to understand, cerebral blood flow is tightly autoregulated in a healthy individual, and that is to say that between most mean arterial pressures of sort of 70 to 150 in adults, we have a stable cerebral blood flow, as you can see by the blue line in the diagram. Unfortunately, however, after neurologic injury, this can be disrupted, and that means that for every increase in your mean arterial pressure, you can actually have an increase in your cerebral blood flow. So it's important to keep a close eye on your patients, but understand that in general, in a healthy individual, this is tightly regulated. So this brain is about 15% of the cardiac output, so about 750 mLs per minute is the cerebral blood flow in adults. Just a few equations to know here that cerebral blood flow is the cerebral perfusion pressure divided by the cerebral vascular resistance. And we talked about the cerebral perfusion pressure on the last slide being the mean arterial pressure minus the ICP. And looking over here, here are things that have significant effects besides for just the mean arterial pressure on cerebral perfusion pressure. The red line, you'll notice that the PaCO2. And so this is what we talked about when we talked about targeting an end tidal CO2 of 35 to 40. Because as your PaCO2 goes up, you get increased cerebral blood flow to help you blow off that PaCO2. So when you target a tight PaCO2, you can help control the cerebral blood flow in an area that permits appropriate amounts of oxygenation and appropriate amounts of flow without causing significant increases in cerebral blood flow that can increase your ICP. And then you see with your PaO2 that at high PaO2s, you can have, but in it is really the reverse is the best way to say this than the mean arterial pressure. But again, it has tight autoregulation across the vast majority of your PaO2s, whereas the CaO2 is linear. And so things that affect your cerebral perfusion pressure include your ICP, your PaO2, and your end tidal CO2, in addition to your MAP. So what is the targeted cerebral perfusion pressure? Well, unfortunately, we don't have...
I don't have an answer for that.
Oh.
Is there...
Suri's trying to answer me, sorry. So we don't actually have data in patients with congenital heart disease, and we have to extract this from patients with severe TBI, and that's because they have ICP monitors in, so we can actually much more closely calculate what an appropriate cerebral perfusion goal is. The evidence in adults is better. It's class 2 evidence in adults, whereas in pediatrics, the evidence is class 3 and somewhat extrapolated from adults. But what we know is that many studies have shown that in children with severe TBI, if they're over 18 years old, so an adult, they need to have a cerebral perfusion pressure of 50 to 60 millimeters of mercury in order to have a good outcome and decrease their mortality. In children between 6 and 17, it should be over 50. And in children between 0 and 5, it should be greater than 40. This does not include neonates, though, because with their fontanelle, there are just different things to take into consideration. And so really in children sort of over a couple of months old up to 5 years, they should have a cerebral perfusion pressure of greater than 40. What we do know from all of the studies is that the cerebral perfusion pressure of less than 35 millimeters of mercury increases mortality in children under the age of 5 years with an underlying brain injury. So keeping in context that cerebral perfusion pressure is MAP minus ICP, if you know that your ICP is at about 15, 15 plus 40 would suggest you need a MAP of 55 in a child of 5 years old to maintain a cerebral perfusion pressure of 40 if they have a significant neurologic injury. So what is ICP and sort of what dictates what causes increases in ICP? Well, ICP, increased intercellular pressure, is the concept that we're going to talk about here is known as the Monro-Kelly doctrine. And basically inside the skull, which is a fixed box, is the brain, which is about 1,400 mLs. There is CSF, which in an adult is about 150 mLs. And there's about 75 mLs of blood. And in a normal state, the blood outflow is equal to the blood inflow. And we talked about how you can have changes in your CO2 and how that will increase blood inflow. But in a normal state, then you should have an increase in blood outflow. That CSF absorption is equal to CSF production, and that you make about 20 mLs per hour, and that you absorb about 20 mLs per hour. And as I mentioned, that intracranial pressure normally is between 5 to 15 millimeters of mercury in a supine position, and 8 to 20 in a, I apologize, lying down position. Other way around. So it's 8 to 20 in the supine and 5 to 15 in standing. I apologize. But what happens when you have changes in those three components? What happens if you have a significant stroke and the brain has a lot of swelling? Well, all of a sudden, as you can see in our diagrams down here, if you have more brain, then you need to have either less blood in the brain or less CSF. Because eventually you get to the point where you have no room within this fixed box and you have a volume that every small increase in volume causes a drastic increase in pressure, and this can eventually lead to herniation. So modulators of ICP. So what increases ICP? Well, increases of ICP include hypertension, pain and anxiety in our patients, venous congestion, suctioning, intubation, coughing, all can cause increases in intracranial pressure. Hypercapnia, as we talked about, CO2s in the 50s, causing increased blood flow can cause an increase in ICP. Hypoxia, as we looked at that diagram, as the O2 goes down, can cause an increase in ICP by increasing cerebral blood flow. Shivering and seizures all can cause increases. Decreases in ICP are really from things like hypocapnia. So if you have a patient that has an increased ICP, you can momentarily bag them down, bringing their CO2s into the low 30s and even the high 20s to acutely decrease their ICP. Hyperoxia, hypothermia, as we talked about, that is potentially a treatment for increased ICP. You can use a drain of CSF, like an extraventricular drain or a VP shunt. Hypoosmolar therapy can decrease ICP by actually shrinking the brain tissue temporarily. Sedation and analgesia and neuromuscular blockade can all acutely decrease intracranial pressure. So I'm going to take a moment to talk about near-infrared spectroscopy, or NIRS, which is a way to measure transcranial oximetry in a localized area. And the goal here is early detection of cerebral ischemia. So the goal, it measures primarily venous tissue saturation, and it's regional, it's under the probes. A normal venous saturation is 70 to 80, but that's a patient with normal saturation. So it has to be adjusted for a patient who may have a baseline saturation of 80 with a hypoplastic left heart syndrome to know that their normal venous saturation will then be 50 to 60, or even as low as the high 40s. And that real-time indicator of changes is really what the goal is here. And what this permits you to do is see acute differences between the two hemispheres where the probe is set up, and look for changes in cerebral oximetry and potential early signs of cerebral ischemia. So it's can be used for patients with neuromuscular blockade, septic patients with worsening perfusion, patients with seizures. It can be an early detection sign if you see an acute drop in one hemisphere, or even an increase because they between the change in hemispheres where one is acutely much higher than the other. And it can be used to assess CPR quality. And just to give a little bit more understanding, it uses near infrared light to penetrate through the skin and onto the scalp. The last thing that I'm going to talk about under prevention is targeted temperature management, which, as I hinted at, is one of the easiest things that we can do at bedside to provide neuroprotection for our patients. So in general, poor outcomes after stroke, cardiac arrest, and traumatic brain injury are associated with pyrexia, so a temperature of greater than 38. The goal is normothermia with 36 to 37.5. And as I mentioned, there are multiple methods to get to normothermia. Randomized control trials have supported therapeutic hypothermia in adults after VF arrest, and HIE in term neonates, for ICP management, and for out-of-hospital cardiac arrest in children. As we talked about, keeping their temperature as low as 34 for 2 days, and then doing targeted temperature management of normothermia for 3. So finishing off, halting secondary injury. So what I want to emphasize here is that early identification and anticipation, which you've been doing, is critical. And when you're concerned, sort of flag the alarms, because time is brain. Seizures, as I've said before, are both a symptom and a disease. Seizures are a sign of an unhappy brain. Blood in the brain, edema, ischemia can all result in seizures. The highest risk for non-convulsive status, so seizures you cannot see, is a history of a clinical seizure. So if you have a child that had one seizure and then isn't waking up, there's a high chance that they may be actually seizing continuously, but you can't see it now, it's all in their brain. And then the other thing I want to sort of emphasize is seizures beget seizures. So if you have a patient who's been in status epilepticus for over 3 hours, the GABA receptor, which is the major inhibitory mechanism in the brain, actually starts to endocytose into the cells. And so again, it's a feed-forward mechanism. It's more excitation, it's more seizures. If a patient without a history of seizures has a seizure, you need to react and investigate quickly with imaging, EEG, loading with an AED. And I'll just mention that febrile seizures are highly atypical outside children of 4 years of age. So it's important not to just assume that the child was febrile and that was why they had a seizure. Very quickly, imaging modalities available: CT, CTA, MR, MRA, MRV, for concerns of prognostication and early diagnosis of ischemia, stroke, prognostication after cardiac arrest. I won't go through all of this. We touched on the modulators of ICP, but if you have a patient that you're acutely concerned about having ICP, here is a summary of some quick methods to help decrease it. And then I want to know, to kind of finish off the last couple of slides by saying this is a really difficult balance. As we've discussed, these patients are at high risk given their physiology. They're born with vulnerable brains. But then we have to take into fact that, you know, some of them, you have to do things like keep them mildly hypercapnic to improve their Glenn flow after a Glenn procedure. That Glenn's and Fontan physiology are dependent on passive blood flow. And so that some hypercapnia, which can cause mild acidosis, can improve a Glenn flow because of the mild elevation in CO2, resulting in decreased cerebral vascular resistance and increased cerebral blood flow. This in turn can increase the venous return to the Glenn, to the SVC and the Glenn, resulting in improved PaO2 and oxygen saturation. But as we also talked about with the Monro-Kelly doctrine, in a patient who's already at a non-compliant sort of system in their brain, this hypercapnia can cause an increase in cerebral blood flow and an acute increase in ICP. And so balancing the physiology of the heart and the brain in these patients can be complex. And, you know, keeping in mind that a patient that may have had a significant neurologic injury may have to be kept more heavily sedated and maybe potentially not being able to be extubated as early as one would like post a Glenn or a Fontan procedure. So finishing off the last couple of slides, I know I'm out of time. This was a study conducted in, again, in adult ICUs across Canada by Victoria McCready, but it really showed that you don't need to have huge neurocritical care units to improve the outcome in severe traumatic brain injury, that processes of care improve outcome in patients. And this looked at isolated brain injuries, but it's really more about standardized management protocol and knowledge at the bedside. And so how does protocols improve patient care? Well, it facilitates communication. It reduces cognitive load so that the team is all sort of having a shared mental model about what the risks for these patients are and what the next step is. It coordinates the interdisciplinary team, and it increases adoption of evidence-based interventions, improves adherence to guidelines. And just so everyone sort of has an idea of what I mean by this, here is some of the ones from the Hospital for Sick Children. Here is our guideline for stroke. Here is neurovital targets that can be placed in the computer for a patient after a stroke or a cardiac arrest, or even on a daily basis to make sure that they have end titles that are neuroprotective, that they have maps that encourage a good cerebral perfusion pressure. And here is our seizure management protocol, offering quick first-line meds for a patient who has status epilepticus. So the take-home messages are children with congenital heart disease are born with vulnerable brains with increased risk for secondary brain injury. The physiology of congenital heart disease increases a risk for additional primary neurologic insults like stroke and cardiac arrest. That neuromonitoring begins at the bedside with a good clinical exam. Seizures are always a red flag of concern. They're both a symptom and a disease. And the goal is to anticipate, prevent, and halt brain injury And as I mentioned, time is brain. So finally, thinking about your patients, they have vulnerable brains. They're at risk for things like cardiac arrest and stroke. And on top of that, that the brain has a propensity with small changes in things like CO2s to have secondary brain injury, which decreases your functional outcome. So the goal is neuroprotection, including avoiding hypotension, avoiding hyperthermia, preventing seizures, decreasing metabolic demands. With this, I thank you all for your time and apologize for running a little bit over.
Thank you, Nicole. That was an excellent review and really built on all the previous speakers for today. It was excellent to hear about the focused review of the breakdown of the bedside neurological exam and some of the simple strategies you use to communicate with the children to do the tests that you say, and also really most importantly, identifying the neurophysiological targets, neurovital signs, and targeted goals for cerebral perfusion pressure, as well as reinforcing how we can modulate the increased ICP using appropriate strategies. Thank you so much.
All right. Thank you guys so much for having me.
So our final speaker of the day, I'm just going to stop the recording and do another